السلام عليكم دكتور إيهاب.
عليكم السلام ورحمة الله.
احنا كده جاهزين نبدأ إن شاء الله.
Okay. Bismillah ar-Rahman ar-Rahim. Today we are going to continue our case discussions, and goal is to get trained on doing smart clinical thinking, smart clinical approach. You have to start with a broad differential, and then as you go deeper into each case, you will narrow the differential and try to reach a final diagnosis. Some cases are very easy, straightforward. Some cases are not. But the critique that follows every MCQ or the discussion of every case is very, very educational, has a lot of information and data not available in any other resources. Today, we were supposed to discuss fluid and electrolyte disturbances and management in the newborn, but unfortunately, we had to reschedule. So I will discuss some MCQs and cases with you. Everyone is allowed to have a comment or have a question at the end of each case. Okay. You see my screen?
هي مش باينة عندي يا دكتور إيهاب.
مش باينة عندك؟ عندكم كلكم مش باينة؟
يا دكتور، هو باين خط رفيع في النص بس، جزء منها صغير.
Question number 13 and this is the case.
لا يا دكتور، في مشكلة في الشاشة. ممكن حضرتك تقفل الشير ونبدأ من تاني؟
Stop share and reshare again. Okay.
تمام.
Share screen. You see it now?
أيوة ابتدت يا دكتور تظهر.
Okay. Okay. So, can we start?
أيوة يا دكتور.
This is a 36-hour-old baby, was a 29-weeker, birth weight 900 grams, has respiratory distress, required CPAP, 6 centimeter water, and 21% oxygen. Enteral maternal breast milk was initially withheld owing to abdominal distension, but the neonate is now spontaneously stooling, and abdominal appearance has improved. The preterm birth was the result of a spontaneous premature labor. So the most common cause for spontaneous preterm labor is infection. And on admission to the NICU, blood culture was obtained, treatment with ampicillin and gentamicin initiated. The blood culture has not demonstrated any growth. So 29 week or 900 grams, respiratory distress, spontaneous preterm labor, CBC and def and blood culture negative, started on ampicillin and gentamicin, and the care team discussed extending the antibiotic treatment for 3 more days. 3 more days, okay? So the baby is at 36 hours to about 1.5 days, and they want to go further on antibiotics for 3 more days. Based on this piece of information of the following, extension of antibiotic treatment in this infant is most likely lead to extension of antibiotic in this particular baby, 29-weeker, for 3 more days with negative blood culture and normal CBC and def, already received ampicillin and gentamicin. Extension will lead to decreasing the risk of ROP, will lower the risk of retinopathy of prematurity, or earlier discontinuation of ventilatory support if the baby was on the vent. Increased risk of developing necrotizing enterocolitis, or increased risk of echogenicity on neuroimaging. So going further on antibiotics, with the baby, preterm baby who has negative blood culture and already received ampicillin and gentamicin, will lead to ROP, earlier a discontinuation of oxygen support, increased risk of necrotizing enterocolitis, and increased risk of echogenicity and neuroimaging, brain problem. So rehab C, answer C, C, C. So most of the answers are C. C, C, C. Okay. So if the answer is C, why? Why this baby, if we go more on antibiotics, has a higher risk of developing necrotizing enterocolitis? Why is that? Dysbiosis. Yeah, make it. Do you need to like this? This is a very brief explanation, which is good. Bacterial dysbiosis. And this is going to lead to what? What is the cause of necrotizing enterocolitis? Interruption of normal microbiome. Yes, good. And flourishing of unfriendly bacteria and fungal infection also, or fungal colonization, which can lead to necrotizing enterocolitis. Yes.
يعني النهارده كده اول يوم ما ناكلش فيه كده خالص.
Sorry?
يشرب بس.
Huh? Raise your voice, please. Yeah, this is an easy question. Antibiotic treatment is common in patients in the neonatal intensive care unit, and but it has decreased. The goal is to decrease unnecessary antibiotics in the neonatal intensive care unit. And because this will lead to the, in addition to the increasing the risk of neck in preterm babies, also it will lead to the appearance of very resistant bacteria. And you have this problem in E.U.P, and you have Klebsiella that is resistant to most of antibiotics, which is something very serious. And I believe it's in all or in most of the intensive care units for infants or for newborn or for adults even have the same problem, Klebsiella. So among preterm infants, less than 32 weeks and 6 days, extended use of antibiotic in the setting of negative blood culture increases the risk of necrotizing enterocolitis, sepsis, and death. So this based on studies. Unnecessary antibiotics in a newborn infant preterm negative blood culture increases the risk of necrotizing enterocolitis, sepsis, and death. Something very serious. So before you prescribe or order antibiotics to your preterm baby in the NICU, think many times. Does this baby need it or not? If not, don't use it. The critique. Antibiotics are among the most frequently used medications definitely in the NICU. Most of the babies admitted to the NICU will receive antibiotics. And because sepsis is a serious problem and a leading cause of death. So, but there was some guidelines based on studies. A recent cross-sectional study by Flaney at 2023 demonstrated significant reduction in antibiotic exposure. This was the plan. Since 2009 up to 2021, they could reduce the amount of antibiotic use dramatically. And this was reflected on the incidence of NICU, sepsis, and death. Okay? The extreme low birth weight neonates in the vignette is extremely low birth weight neonate in the vignette is experiencing respiratory distress after delivery because of unexplained preterm labor. Because of the risk of sepsis, a blood culture was obtained, empiric antibiotic treatment initiated, which is okay, so far so good. At 36 hours of age, the neonate remains on CPAP, mild respiratory distress, and no other signs of sepsis, no sepsis clinically. The blood culture has not grown any bacteria, so extending the duration of antibiotic treatment increases the risk of neck and also sepsis and death. This is the homegoing lesson. If you have a preterm infant in the NICU with a negative blood culture, and once you cover the baby with broad spectrum antibiotics till the culture results come back, which is usually 48 hours, and the culture comes back negative and the baby does not show signs of sepsis, please stop antibiotics. This is the homegoing lesson. Comments, questions? Comments, questions? Blood culture results are usually very late, take 10 days. So, no, this is not correct. No, the blood culture does not take 10 days. This is not correct. The blood culture, if it does not show growth by 48 hours, 99% it is negative. And to confirm, you have to keep the growth, checking for the growth up to 5 days. And if you hold it for fungus, it might take up to 7 days. Otherwise, 48 hours, no growth, stop antibiotics. Okay? Any other comment or question? Okay. Keep going. The coming question is extremely important because it is tailored to the situation in many areas in Egypt taking care of preterm babies where they don't have echo, cardiac echo. And as we are going to see from the question, the ongoing lesson will be how, by using your clinical sense, history, physical exam, and handy workup, X-ray, EKG, but no echo, you can reach at least, or you can limit your differential, and you can even start managing this baby till you have the luxury of doing the echo, or you have a cardiologist, or you can refer the baby to another more advanced NICU.
دكتور إيهاب معانا معلش سؤال في Q&A بيقول does antacid increase the risk of neck in preterm?
Yes. Yes, sure. The H2 blocker or proton pump inhibitors, if they are used unnecessarily, so you will gain the risk without gaining any benefit. And the risk is they change also the microbiome, they cause dysbiosis also, and expose this baby to infection. Correct, yes. The answer is yes. Okay, start with this question. This is a term infant C-section at a community hospital. Community hospital meaning underserved area. They don't have much resources as in level 3 or level 4 hospitals that can support and do everything for the newborn baby. Everything was normal prenatally. The baby had some respiratory distress and was on CPAP because of increased work of breathing. And the oxygen saturation, this is the key word. Oxygen saturation measured by pulse oximetry on the right hand is 100%. While the baby was receiving, sorry, is 80%. I'm sorry, I'm jumping. 80% while the baby was receiving 100% of oxygen. So what does this mean? When you have a baby with the pulse oximetry on the right hand is 80%, and this is on 100% of oxygen. What does this mean? Is this normal or abnormal? And what does the right hand mean? So, chat. Hypoxia, preductal cyanosis, yes. Jamila CCHD, congenital cyanotic heart disease. How did you know that this is heart? How can you tell this is cardiac? It is just preductal hypoxia or preductal low saturation. It is as simple as that, meaning cyanosis. Okay, cyanosis. This baby is cyanotic. And I have a very good lecture I will present it to you at some point about how to evaluate cyanosis in the NICU, in the newborn infant. It is very, very important and educational lecture. Inshallah, soon I will present it to you. So this baby is cyanotic with mild respiratory distress. Maybe because the respiratory distress is mild, you will think more of cardiac. Okay. Vital signs, blood pressure is okay. And this is important. Why this is important? Because many of the congenital heart diseases present with shock and hypotension. So this baby blood pressure was appropriate. Heart rate 123, so there was no tachycardia. So this baby was not, if any, if he had heart failure, it was not severe. Respiratory rate is 64, borderline high, which may or may not be respiratory or cardiac. It could be both. The lung fields are clear to auscultate. This is important. Lung fields are clear to auscultate. Usually, there is no respiratory, but this does not rule out respiratory 100%. I give you an example. If this baby is having congenital cystic malformation or CPAM, you will not find, you may not find signs on auscultation, but the baby might be having respiratory distress. A single heart sound, oh, this is important, another key point. What does a single heart sound mean? And depending on the location, it can be either or. So, single heart sound, this diaphragmatic hernia, why you jump to this diagnosis? Pulmonary stenosis. If the second heart sound is single, at the left upper sternal border, usually it is pulmonary stenosis, yes. And there is a grade 2 systolic ejection murmur at the left upper sternal border. So we are dealing with something wrong with the pulmonary artery. But we have to proceed. Pulses are palpable in all four extremities. This is going to rule out what? Coarctation of the aorta. مش كده? Yes, coarctation of the aorta. And the liver is not enlarged, which means that there is no moderate or severe heart failure, if any. So this baby might have mild heart failure or compensated heart failure, but definitely it is not moderate or severe. Then comes the EKG. They did an EKG, which we are going to discuss. And they did an X-ray, which we are going to discuss. Okay? And yes, and they did a gas. They did a pre-ductal gas. Do you hear me now?
Yes, Dr. Ehab.
So since when you didn't hear me?
We did pre-ductal gas.
Yeah, so it just muted. So the keywords, C-section, term, infant, mild respiratory distress because of increased work of breathing, 100% preductal on 80% preductal on 100% oxygen, and heart rate is appropriate, blood pressure is appropriate, respiratory rate is borderline, lung fields are clear to auscultate, single heart sound and ejection murmur grade 2 at the left upper sternal border, which means definitely pulmonary problem, pulmonary valve problem, most probably stenosis. Pulses are palpable, no co-arc, liver is not enlarged, there is no major heart failure. We are going to look at the echo, at the X-ray, and at the preductal gas on 100% oxygen. At this point, what is your differential? And I will give you some hints. When you suspect a congenital heart disease, you have to decide or to make decisions about these important items. Is this congenital heart critical or not critical? Critical means immediate intervention. Like, example, if the baby is in massive heart failure or in shock, like obstructive left cardiac outlet lesions. Okay, and then is the cardiac problem cyanotic or non-cyanotic? Because this will give you a clue to the diagnosis. And then important, very, very important issue, is it ductal dependent or not? Ductal dependent or not? Okay? So is it critical or not? Cyanotic or not? Ductal dependent or not? If you don't answer these questions, you will not be able to manage this baby. Okay? And as I told you, the homegoing lesson from this case, which might not be very difficult, but it shows you how important is the clinic. The clinical is extremely important. History, physical exam, and then bedside labs that are very easy to do, like blood gas, pulse oximetry, X-ray of the chest, 4-limb blood pressure, 4-limb pulses, palpation of the liver. This is all clinical. And without echo, we didn't mention echo because this is an underserved area and they don't have the luxury of having echo. So keep going. And then I don't know if this EKG is clear to you or not, but I will give you a hint. I will give you, no, I will not give you the hint now. I'm sorry, because it will show the answer. Yeah, when you look at an EKG, I'm not an expert of EKG, but you have to know the basics. What should you look at when when the nurse give you an EKG to interpret? Number one, the rate, the rhythm, correct? And then the waves and intervals, and the axis, whether the P axis or Q axis. So, and then you look at different signs of ventricular strain or ventricular heart failure or ventricular hypertrophy. So what is wrong with this EKG? Oh, you didn't answer my question. What is your differential at this point? Before you look at the EKG, what is your differential? PPHN. PPHN. It could be idiopathic PPHN. It could be, but why the PPHN will cause an ejection murmur? Why should it cause the second heart sound single? Huh? So you have to rule out PPHN. So we are dealing with a congenital cyanotic heart disease, most probably. This case is not respiratory. It is cardiac, and it is not PPHN. So if it is cardiac, is it critical or not critical? Is it ductal dependent or not ductal dependent? It is cyanotic, yes. So what is your differential? Non-critical. Why you said non-critical? Based on what? Why you said non? Because the baby is still hemodynamically stable? Yes, you are correct. But maybe in 2 hours, this baby will succumb and will be very, very sick. But at this point, maybe it's non-critical, but you are not 100% sure. You have to be sure. Cyanotic, yes. Ductal dependent, how did you know? How did you know it's ductal dependent? It is critical? Most probably, yes. Critical cyanotic duct dependent, most probably. You have to take this into consideration until proved otherwise, because this is the extreme of the scenario. And because you don't have the luxury of echo, assume this is a critically cyanotic ductal dependent congenital heart disease. So what is your differential? And are you going to give prostaglandin at this moment or not? Pulmonary atresia, tetralogy of Fallot, Epstein, yes. Tetralogy of Fallot, yes. Pulmonary atresia, yes. Pulmonary atresia. Failure of hyperoxia. We didn't do the hyperoxia test, by the way. We just give 100% oxygen and did pre-ductal. Saturation and gas. So let us proceed. EKG. What is wrong with this EKG? Is the rate abnormal? Is the rhythm abnormal? You think there is arrhythmia? No, it is not tachycardia, it's not bradycardia, it's not arrhythmia. So what is wrong with this? If you look at, I will make your life easier. This EKG will, by reading it, is it right axis or left axis? And why? And number 2, is there any ventricular strain or decreased function, hypertrophy, or not? And if yes, is it right or left ventricle? Okay, this will make your life easy. Let me see, what do you think? Right ventricular enlargement, based on what? How did you find that? Right ventricular hypertrophy, Shayma Saeed. Shayma, are you the nice lady who presented arrhythmia and EKG in the newborn? دكتورة شيماء.
لا يا دكتور، دي كانت دكتورة ميرام لو حضرتك قصدك على scientific.
Oh, okay. She is not with us to help us, because we presented EKG in newborn and arrhythmia. Okay, right ventricular hypertrophy, why? Somebody says no. No what? Left axis deviation, why? Yeah, there is left axis and there is right ventricular hypertrophy, and let us proceed. And this is the X-ray. What do you see in this X-ray? What is abnormal in this X-ray? Boot on, it is not boot on sabot, it is cur on sabot, or boot-shaped heart. You have to decide which of which, Dr. Shayma. So boot, it is not boat, it is boot, B-O-O, not boat. Boat يعني American. Cœur, C-O-E-R, it's in French, cœur en sabot. Or snowman shape, egg on a string. So there is no agreement about what's going on. When you look at the X-ray and try to focus on the heart or the cardiothymic silhouette or shadow, is there a thymus? Yes or no? Yes. Is the thymus shadow appropriate or absent or very large? And then the heart, is it enlarged or not? Is it right ventricle apex or left ventricle? And I think you know how to decide if the heart is enlarged or not. So, and then you should comment on the pulmonary circulation, extremely important. Is it oligemic or plethoric? You think this lung field is oligemic or plethoric? Heart size, mildly enlarged. It is mildly enlarged. And it is right ventricle because the apex is above the diaphragm. Keep going. This is the preductal gas, arterial gas, on 100% oxygen, which is part of the hyperoxia test, but it is not the hyperoxia test. pH 7.21, PCO2 31, PO2 42, bicarb 18, base deficit 7.6. So I need to give me two diagnoses from this gas. What do you think this gas is showing? In 2 sentences. What is abnormal with this gas? This is very easy. This is what you do every day. iPhone to every. Mild metabolic acidosis, yes. Hypoxemia, yes. So there is low oxygenation, and definitely there is metabolic acidosis. Okay. And hypoxemia is because of the cyanotic heart, and hypoxemia at some point will lead to anaerobic metabolism and metabolic acidosis. So, question. The infant is intubated, given prostaglandin, and transferred to the intensive care unit where echo is available. Okay? And they did echo to diagnose. Because the gold standard for any cardiac problem is echo. And also it will rule out PPHN. Of the following, before we go to the question. So if you are in underserved area and you have a baby who is cyanotic and you suspect either respiratory or cardiac. You rule out respiratory, so it's cardiac. How can you, without echo, have a differential diagnosis and narrow the differential diagnosis to one or two problems? And how you manage even without echo, as the same as they did prostaglandin, okay? They did prostaglandin to save the life of this baby. If it was not ductal dependent, it will not cause much harm. But if it was ductal dependent, prostaglandin will save the life of this baby. You do good history, you do detailed physical exam, focus on the heart and signs of heart failure. And when you do heart and chest, you do inspection, palpation, percussion, auscultation. You do the same with the other systems. And then you do pulse oximetry, pre-ductal, and you should, I don't know why they didn't do post-ductal. And you do pre and post-ductal gas, arterial gas. You do EKG and an X-ray. And then if you have the luxury of having echo, this is gold standard. It will save you hyperoxia test. It will save you wasting time, and it will help you to reach a diagnosis immediately. Question of the following: the most likely echo finding of this infant is this Epstein anomaly, pulmonary atresia with an intake ventricular system, tetralogy of Fallot, or tricuspid atresia with pulmonary stenosis? What is your, this is the differential I asked you about. You didn't mention this, the last one. You didn't mention the last one. Tricuspid atresia with pulmonary stenosis. So is it A, B, C, or D, and why? D, C, C. So you are divided between C and D. Is it Epstein? In Epstein, you don't find a single second heart sound. You don't hear a murmur on the left second intercostal space. And the EKG totally different. The X-ray is totally different. It's not Epstein, definitely, and we are going to see why. Pulmonary atresia with an intact ventricular system. It can give you this huge heart size, cause the cyanosis. It's ductal dependent. But the other auscultatory findings and EKG findings are different. Tetralogy of Fallot. Is it tetralogy of Fallot? And you should know that tetralogy of Fallot has a wide spectrum of presentation. It could be asymptomatic. It could be pink Fallot, or pink Fallot, tetralogy of Fallot. It could be severe. Is it tetralogy? We'll see. Is it D? Why D? Why you said D? Based on what? Based on what? Tricuspid atresia is superior axis deviation. Not so. I think you read this MCQ. Hala, you read this MCQ, correct? I don't like that. I told you, don't do Google, don't do AI, and don't sneak around and go to the question. Can you tell me, Dr. Hala, why you said it's a superior left axis deviation? Why? Why it is superior left axis deviation? If you don't say why, you don't know the answer. How did you know that it's superior left axis deviation? No, it is not followed. It is not followed. It is tricuspid atresia with pulmonary stenosis. And let us proceed. Left superior, I don't know. I don't know what does superior mean. And that's why I thought you read it. You sneaked around and went to the question and you read it. We know left axis, that pattern, but superior, I don't know what does superior mean. So it's left axis, and we are going to know how you can tell if it's left axis or right axis. And this is very characteristic of tricuspid atresia without transposition, because some types, the tricuspid atresia have types. Type 1, type 2, some of them are with TGA, some are not associated with TGA. Physical exam, chest radiography, echocardiography, and an arterial gas PO2 concentration while receiving 100% oxygen can help guide the initial management. This is the homegoing lesson. We suspected congenital heart defect when echocardiography is unavailable. This is the homegoing lesson. I know many of you don't have the luxury of having handy echocardiography, and you don't have handy cardiologists to consult. So you have to depend on yourself. So you do physical exam after taking good history, chest radiography, EKG, pre and should do postductal oxygen saturation and pre and postductal ABG while on 100% oxygen. And this is going to guide you. And then you go for the echo or send the baby for another area for echo. And if you have prostaglandin, give it before sending the baby to the other NICU. Okay. When you have an EKG, you should comment on the following: the rate, and there is a way to calculate that. I will not go into these details. The rhythm, the axis, and the axis is either the p-axis or QRS axis, and usually they use this one. Comment on the P wave, QRS complex, QRS, where you have to discuss the R deflection and S deflection, T segment and T waves, and the intervals, PR interval, QRS interval, QT, and there is a correction for these for newborn based on certain equations. I will not go into these details. So this baby did not have problem with the rate and rhythm, have left axis. We are going to see why. And based on the QRS complexes in the different leads, the S deflection and the R deflection and the S deflection, baby has right ventricular dysfunction. Okay. Okay. There is different ways to know which axis is the baby or is the EKG. Is it normal axis in this area? Or is it left axis in this area? Or is it northwest, which doesn't mean anything? Or right axis? And normally the heart in the newborn baby is right axis and the right ventricle predominates and the apex is right. So you look at the two leads, lead 1 and AVF. You look at lead 1, you look at lead 1 and lead AVF. And based on that, you can decide, is it right, left, or or whatever, something else. You look at the deflections. In the normal, in the QRS complex, the R waves, R deflections are pointing the same direction, up, pointing up. This is normal. The range varies between newborn and older babies. In the newborn, between, I believe, minus 30 and 90. I think it is the same as in older babies. Left axis, when they are looking at two different directions. They are looking at the two, yes, this is the main deflection in the lead one, and this is the main deflection in the AVF. If they are looking away from each other, it is left. If they are pointing to each other, this is right. This will make your life easy. So when you look at this EKG, our EKG in this case, yeah, look at lead one and the AVF. This is the main deflection, R, and this is the main deflection, the S. So they are looking at two different directions. Exactly this picture. So it is left axis. I don't know about superior, I'm not cardiologist. Okay? How you can tell there is a right ventricular strain or dysfunction? I will tell you. Okay. Okay. This is all the methods to discuss, to diagnose the X. We'll find it somehow, how to diagnose right ventricular strain. So this is how to assess an EKG. This how to do the axis. Either P or QRS axis, and you look at the RS deflections in lead one and lead AVF and see if how they look like, pointing same direction, pointing to each other, pointing to different directions. Based on that, you'll decide, is it left or right axis? Critique. Okay. Right-sided congenital heart lesions can present with severe cyanosis and cardiomegaly immediately after birth. This baby did not have massive heart cardiomegaly. It was mild, as shown by X-ray. Obstruction of the right ventricular outflow to the pulmonary artery result in shunting of blood across the atrial septum or the ventricular septum if available, if present. So there is right to left shunting, and this is the reason of cyanosis. If you have this right-sided obstructive lesion, there will be shunting of blood across the ASD, VSD, right to left shunting, causing cyanosis, and because of the more pressure on the right side, there will be cardiomegaly, hypertrophy of the right ventricle. So, and then you do echo. After that, you do echo. Although not diagnostic, these studies will often suggest, these studies, the clinical one, the one I talked about, the physical exam, the chest X-ray, the EKG, measurement of pre and post ductal oxygen saturation and blood gas, if echo is not available, they are not diagnostic, but they will often suggest a diagnosis and guide early treatment until diagnostic echo can be performed. This is the homegoing lesson. This is extremely important, especially for those who work in underserved areas. Okay? So, interpretation of the EKG. This baby had mildly enlarged heart and reductal hypoxemia, cyanosis in 100% oxygen. And EKG is notable for left axis, as we said, and diminished left ventricular force. How you diagnose this? Diminished right ventricular forces by decreased R waves in lead one, V1, V2, V3, and increased S wave in the left leads V5, V6. So in the V1, V2, V3, there will be decreased R wave, and in the leads V5, V6, you will notice increased amplitude of the S wave. Back to the EKG. Back to the EKG. Yes. So in the V1, V2, V3, there is reduction or decrease in the R wave. Okay? And in the the left leads, there is increase of the S deflection, Is this correct? V1, V2, yes. Okay. Again. Okay. Decreased R wave amplitude in the right leads, V1, V2, V3. And increased S wave amplitude, S wave was increased in the left leads. Okay? You see this? And diminished R waves in the right V leads and increased S. And sometimes they do RS ratio. And if it is less than 1, usually it means right ventricular strain. I'm not expert in the EKG, to be honest with you, and usually I depend on the cardiologist. But this is if you are by yourself. Okay, I will not go into details because this will take a long time. But I will try to refer to the different anomalies. So, tricuspid atresia, like 1 in 20,000, 1% of all congenital heart. The clinical presentation depends on the presence of associated defects. If there is VSD, subpulmonary stenosis, pulmonary stenosis, usually it is complex congenital heart disease. TGA, congenital heart disease are not as easy as we used to know in the past. They are usually, most of the babies have complex congenital heart disease with a predominant lesion, okay? But we don't have to go into these details. And it has a systolic ejection murmur. It has a single second heart sound, and the heart may be mildly enlarged. And the closest differential is tetralogy of Fallot. This is the closest differential. In the Epstein anomaly, also 1 in 25,000, what happens is there is encroachment of the right atrium on the right ventricle. There is atrialization of the right ventricle. And this is what happens. There is atrialization of the right ventricle. Right atrium is large at the expense of the right ventricle. And this is Epstein, and usually this is the X-ray. It shows when you see this picture, severe cardiomegaly, your differential is limited to like four or five congenital heart disease, among which is Epstein. And definitely the EKG is very diagnostic. The very prominent P waves, very prominent P waves. Pulmonary atresia with intact ventricular system is another differential. And this is the, yes, the septum is intact, but there is pulmonary atresia. This is the second differential, but although the heart is, you see, it's humongous cardiomegaly, but the EKG is different. There is normal sinus rhythm. The axis, QRS axis is between 30 and 90. P waves are tall. And there may be also ST changes of myocardial ischemia. Tetralogy of Fallot, the most common, this is what we see very common. The incidence is much higher, 3.3 per 10,000. And we know that it is made of 4 components. And this is, yes, there is overriding aorta. It takes blood from both sides, right and left ventricle. That's why there is cyanosis. And there is VSD. And there is some degree of pulmonary stenosis and right ventricular hypertrophy. And this is the cœur en sabot or boot-shaped heart. Boot, not boat, boot-shaped heart. It looks like the gasma, كأنه gasma. ماشي. And this is the EKG in tetralogy of Fallot. Dominant R waves and upright T waves in V1. In V1, dominant R waves and upright T waves. It's not down, it's high. Okay? And this is, I know that you do for every and each baby, before you send this baby home, you should do the critical congenital heart disease screening. And I think all of you know how to do it. You do pre and postductal saturation, and then if it's abnormal, you repeat. If it's abnormal, you do cardiac echo. And it's very, very useful to screen all newborn babies. I'm sorry for this very busy table. I usually don't do that. I usually divide them. But it gives you some of the congenital heart defects with the ductal dependent lesion. And this is I will send all this to you, the characteristics of every and each of those common heart. This is not, okay. And this is the hyperoxia test, how you do it. If you have the luxury of getting echo, you don't need to do a hyperoxia test. If you don't have hyperoxia test, what you do is you do pre and postductal saturation, pre and postductal blood ABG, while the baby is on 100% oxygen for some time, like 30 minutes. And based on that, you can decide if this baby is normal, if he's having pulmonary disease, if he's having methemoglobinemia or congenital cyanotic heart disease or PPHN. We discussed this before several times. So comments and questions. Anonymous attendee. How to suspect ductal dependent without echo? How to suspect? You do, when you do the pre and post ductal oxygen saturation, pre and post ductal ABG, and you compare the saturation in the pre-ductal to the post-ductal and the ABG in the pre-ductal to the post-ductal, and based on the difference between them, you can suspect if this baby is ductal dependent or not. If the pre-ductal is much higher than the post-ductal, and sometimes there is an inverse. There is the pre-ductal, the post-ductal is higher than the post-ductal, like in TGA. But there should be a good difference between both of them. I know it's between 15 and 20, as far as I remember. This is how to decide which, if this is ductal dependent or not. Of course, when you do the echo, you will know. Any other comment or question? Box shape. What is the box shape? Shaima, heart tool, R and V1. Box shape. What is the box shape? Tura Shaima, what do you mean by box shape? Pre-ductal and post-ductal saturation. Hyperoxia test. Epstein box-shaped heart. The Epstein is box-shaped. I don't know. I don't know if you read it or not, but I never heard of that. Flask-shaped, maybe, but it's humongous cardiomegaly. And this is Epstein and tricuspid pulmonary atresia, massive pericardial effusion. This is among the differential diagnosis of this massive cardiomegaly. Flask shape. No flask for pericardial effusion. I don't know. Are you? You are talking to each other most probably, but not to me. Any comment or question? The lung should be oligemic. True? Yes. Yes. The lung should be oligemic, but I don't know. It depends on the exposure of the X-ray. They didn't comment on that. But if it is tricuspid atresia with pulmonary stenosis, yes, the lung should be oligemic, not plethoric. You are right. Questions. How to suspect how the lung should be? Yes, yes, you are right. Anonymous, you are right. What about if CRP is positive, to discontinue or extend the course of antibiotics? I talked hundreds of times about the value of CRP in the management of sepsis. CRP does not diagnose sepsis. The gold standard is the blood culture. And then you have some indirect evidence of infection, like neutrophilia or neutropenia, like inflammatory markers, for example, CRP, ESR, and others. It is important, if it is high and you are dealing with a case of sepsis, it will confirm your diagnosis. And once you start treatment, the value of CRP comes here. in the follow-up of the response to treatment. If with treatment it drops to normal, meaning you are moving in the right direction. So this is the main value of the CRP. And this was about the question, the previous question. I need to move to another MCQ. A 30-weeker, and I believe we discussed similar cases, but this is a common issue that you will find in the NICU. So I will go fast through this case. Admitted to the NICU, a 5 French umbilical venous catheter is easily inserted in the first attempt. Shortly after admission, and parenteral nutrition is initiated through the catheter, and it was removed by the age of 5 days after birth. This is the initial X-ray, and this is the UVC. What is your comment about the position of where is the tip of the UVC? You think it's normally positioned, or it's high, or low? What do you think? This is a very common practice. You do it every day. Where should the tip of the UVC be at when you insert a UVC and do an X-ray, a babygram, and you look at the babygram and say, oh yes, it is in good position, or no, it's too high, or it's too low in the liver? So what do you think this is, and where should it be? No neonatologist is attending with us. The UVC is adductus venosus. You didn't answer my question. Is it high, low, or at a good position? You didn't answer my question. T just be 9 to 10, a little but low. Good position. You think it's good position. 9 to 10. Is it 9 to 10? Just below the diaphragm, the dome of the diaphragm, not the diaphragm. Good position. Yes, the people who made this MCQ believe it's in good position, but I don't believe it's in good position. I believe it's low. It should be at least at T9 or at the dome, level of the dome of the diaphragm. Should be here. But they thought it's normal. I don't know why. Okay, by day of life 7, this baby started to develop apnea, bradycardia, non-bilious emesis, and however was hemodynamically stable, still stable. Had mild abdominal distension. Okay. And then they did laboratory studies, including CBC and DEF with C-reactive protein, serum electrolytes, hepatic function panel. They all were within normal. There was no evidence of infection. However, when they did an X-ray, again, they found small lucency overlying the liver. Okay? And when they did ultrasonography, they found septated intrahepatic cystic lesion with internal debris. What is your differential? What is your differential? You had an UVC. They thought it's in good position. I believe it was low. They give TPN through it. I believe it was in the liver, or it migrated at some point, but definitely something related to the UVC happened. In X-ray, looked like this lucency, sorry, this hyperlucency in X-ray, and this is by ultrasound, a cyst that is having septation and internal debris. What is your differential? This is an easy case, and you can see it any day, any time. Calcium necrosis, abscess, liver abscess, liver abscess. Why you think it's an abscess? This baby is hemodynamically stable, and they did CBC and DEF, CRP, electrolytes, liver function tests are within norms. Baby is hemodynamically stable. Hemodynamically stable. So why you think it's an abscess? And there was mild abdominal distension. Why you think it's an abscess? Calcium necrosis. Why calcium? How did you know they gave calcium? They didn't mention calcium in the vignette. So don't jump into diagnosis. Abscess, no. Abscess. Thrombosis, yes. But the thrombus will not liquefy that soon and give you a cyst. There is a cyst. This is the lesion. Cyst with septated and debris, and it shows in both babygram and in babygram and in the ultrasound. So thrombosis, maybe, but it's usually takes time to give you the cyst. Abscess, it may be, but why abscess? It's just cyst. It's not filled with fluid, and the baby does not look to be septic. What else? We discussed similar case before. There is a definition. There is a term for a cystic lesion in the liver when you give TPN through a UVC. It is called TPNoma. TPNoma. And because it was not present in initial X-ray, so it's not like hereditary congenital cyst. No, this is not cystic liver. So it is something acquired. So when you have a cyst in the liver, it's either congenital or acquired. Congenital cyst in the liver is a totally different story. It was not present since birth. So this was present after UVC and TPN. So abscess, yes, but we ruled it out clinically. And thrombosis, yes, but it will take time to form a cyst. But there is a term called TPNoma. I will not go into the details because we need to discuss another case. Of the following, the factor most likely associated with this neonate's hepatic finding is malposition of the umbilical venous catheter, wrinkle injury during catheter insertion, and what is in the vignette with or without that rules out any or all of the or most of those options. Prolonged umbilical venous catheter dwell time, underlying hypercoagulable state, meaning thrombosis, as you were thinking of. Answers. Yes. It's malposition of the umbilical venous catheter. And even if you insert the UVC and you think it's in a good position, be careful. You have to follow it up because it might move. Lines move. The PICC line, you can insert a PICC line in a good position and next day it is in the heart. can cause pleural effusion or even pericardial effusion. Be careful. And with effusion with TPN with lipids is not something nice. Same with UVC, it could migrate. They consider the position normal and they think it migrated, but I believe it was not in the good position from the get-go. Never mind. Is it parenchymal injury during catheter insertion? What in the vignette is against this? Five French umbilical venous catheter is easily inserted on the first attempt shortly after admission. So most probably this rules out injury. It was easy, first attempt, they didn't try back and forth several times. Okay, so most probably this option is not there. So it's not parenchymal injury. Prolonged umbilical venous catheter dwell time, they removed the catheter at the age of 5 days. They removed it at the age of 5 days. You think this is a prolonged time? What is the appropriate time for a UVC to be appropriate time? Liver function was not present at first. Oh yeah, the liver function are normal, was not, yeah, 7 days, yes. Usually we can leave the UVC for 7 days. So they removed it in 5 days, so this option also is not correct. Underlying hypercoagulable state causing thrombus. We ruled this out before even we saw the question. So umbilical venous catheter malposition is the most common complication related to UVC and is the most important risk factor for UVC-related hepatic complications. The hepatic extravasation that results from the infusion of hyperosmolar fluid through malpositioned umbilical venous catheter within the hepatic circulation is referred to as TPN-OMA. This is the diagnosis, TPN-OMA. And acute abdominal distension or clinical deterioration in a neonate with UVC should prompt radiographic or ultrasonographic evaluation to assess catheter tip position. Unfortunately, ultrasonography is very sensitive, more sensitive in detecting UVC compared to conventional radiology. And the position should be at the atriocaval junction. Atriocaval junction. So that's why the ultrasound is more sensitive, because the X-ray will not show you the atriocaval junction. Usually we go by level 9 or by the dome of the diaphragm. And they thought of abscess, but the clinical condition and labs were against abscess, and even the X-ray and the ultrasonography didn't show fluid level. So they thought it is TPN-OMA. And important homegoing lesson also is you have to check the position of UVC daily. At least look at the mark. Usually when you tape the UVC, the nurse should write down this UVC was inserted till the mark, like number whatever. If the number is the same, usually it is okay, but this is not also 100% sure. If you do an X-ray, sometimes it moves, it migrates. Okay. Question, comments? Yes, let me take you to the complications and then. Hepatic or portal vein thrombosis. This is a well-known complication, but usually it takes time. And then we talked about the abscess, the cyst, the TPN neoma. Usually it affects the left hepatic lobe. Okay. The atriocaval junction is the proper position. That's why ultrasound is more sensitive than the X-ray. Comments, questions? Any questions? Okay. How to suspect the lung should be TPN neoma is lesion in parenchyma of the liver or the portal vein. It is in the liver. It is in the liver. It is not in the portal vein. When you insert a UVC, okay, what is the route? What are the veins you go through? Do you go through the portal vein? Review your procedure text. Okay. Do you heparinize? Yes, we should. Yes, we don't do lines without heparin. I think it's 0.5 units, or I'm not good with numbers, but the answer is yes. Let me give you a case. Case. Okay, do you see this is, do you see my screen? Do you see the screen?
يا دكتور شايفها.
Okay, so we'll move to case number 13 also. Case number 13.
دكتور في سؤال.
سؤال. Okay.
If
Just
UVC
once.
inserted.
سؤال. If do you heparinize? Yes. Is lipid in TPN contraindicated in sepsis? Don't take us to side tracking, because if you go into outside tracking, will not finish discussion. We are not talking about TPN now. So please focus on the subject. Okay, what is the question?
في الشات يا دكتور دكتورة دينا تسأل if UVC inserted and it's hepatic. Should I remove? It is hepatic.
كاتبة ايه؟
If UVC inserted and it is hepatic, should I remove or we can give fluids or pull it down to low level insertion?
In the UVC, if it is high, the problem is easy. You just do X-ray and ultrasound and decide to withdraw like by 1 centimeter or whatever. If it is in the liver, don't use it. The only option you have is to do a low UVC. You have to keep dragging, taking the UVC out till it is just outside the liver. And in this case, you use it temporarily till you get a PICC line. You use it for IV fluids, you use it for medications for 1 or 2 days, during which you have the option to do a PICC line. You do a PICC line, another central line. Is this clear?
clear يا دكتور.
Okay. Question number 13. A 39-weeker girl, vaginal delivery. Mom is 35 years, gravida 7, para 5015. Mom had maternal herpes, HSV 2, but recurrent, but there is no active lesions at the time of delivery. There was polyhydramnios. Apgar scores were 3, 6, and 7. A baby is on CPAP. Because of hypoxia, they had to go up on the oxygen to 30% and send the baby to NICU. There is no perinatal depression to the baby or HIE risk. Okay. The infant has 2 desats, 2 episodes of desaturation, and had to go up on oxygen again. So the baby is having respiratory distress that is progressive and getting worse and worse. Initial exam within normal. Initial exam was normal. So she didn't have like retractions. They didn't auscultate like diminished air entry or mediastinal shift or crackles or wheezes. It was, the exam was normal. Exam was normal. Respiratory distress with a normal exam. Cardiac exam normal, respiratory exam normal, abdominal exam normal. And baby keeps developing recurrent apneas. This baby is 39-week. Apnea in a 39-week is very concerning. And don't take it lightly. If you have a preterm baby with apnea, no problems, apnea of prematurity. But if this baby is term, there is something serious going on, most probably. And they had to go up on the desaturation went to 40%. The desaturation went to 40%. Okay. During each episode, the patient is noted to have tensed extremities. There is abnormal position of the extremities, rhythmic flexion, and extension movement. So they diagnosed seizure, and they thought the apnea is because of the seizure. Correct? Okay. And then consulted neurology for evaluation and placement of video, EEG, and EEG is ordered and started antimicrobial and antiviral. The apnea episode increased in frequency, and they had to intubate the baby. So my question is, what is your differential? A term baby who has persistent, recurrent, consistent apnea increasing in frequency, causing respiratory distress without other signs, and causing desaturation and required go up on the oxygen and required intubation. And they did an EEG and they gave antimicrobial and antiviral treatment, but the apnea did not stop. Okay. And before we go into the differential, what is your differential? A term baby who has apnea causing respiratory distress and desaturation, requiring at the end, because it was persistent and progressive and increasing in frequency, required intubation, EEG, antibiotics, antiviral, and the baby had seizures. Definitely the baby had seizures, but is it because of the apnea or not? What is your differential? And the differential is very broad. And the idea is to try to narrow the differential as much as you can. HIE, do you think this is a picture of HIE? No, I'm not happy with this answer. HIE, no. How you diagnose HIE? The baby is not encephalopathic at all and did not have any history of hypoxia during perinatal hypoxia and did not have like neonatal depression or very low Apgar scores that was persistent and was not intubated from the get-go. The problem is apnea, not HIE. Please remove this. Stroke, it could be. Hemorrhage, intracranial hemorrhage, yes, it could be. Infection, yes, that's why they did the antibiotics and antiviral. What else? Torch. Torch? No, this is a very remote possibility. Why torch? What is in the baby that makes you think of torch? There is no rash, there is no hepatomegaly, there is no splenomegaly, there is no petechiae. It is a very remote possibility. And the labs of the mom were normal. Meningitis, yes. IEM, I don't know what IEM means. IEM. IEM, what does this mean?
Inborn error of metabolism.
Oh, yes. It could be, but this baby was not fed at all, and also is not encephalopathic, and there is no dysmorphic features, there is no hepatomegaly or organomegaly. It is a possibility, but it is remote. What else? Encephalitis, yes, like meningitis, infection. Brain anomalies, yes. Inborn, yes. Stroke, yes. IC, yes. Hemorrhage, yeah. You covered every and each thing except vein of Galen. What is in the vignette? We discussed the vein of Galen last time. Did you attend this presentation? I don't think so, because it is not the vein of Galen. What is, you go by keywords in the vignette, in the scenario. Vein of Galen, it could be, but nothing in the case will make you think of vein of Galen. Epileptic syndrome, yes, it could be. You mentioned every and each possibility except the actual diagnosis, which will be surprise to you. Intubation was difficult, requiring more than 3 attempts, with successful intubation by the supervising physician. There is something wrong in the upper airway. There is something wrong in the upper airway, causing upper airway obstruction. And before we go to the level of the larynx, there is other possibilities, like quenal-atresia. Quenal-atresia could present with apnea and with cyanosis that improves with crying. This is very specific sign. So upper airway obstruction is a very good example of respiratory distress and apnea in the term baby. Be careful about that. So what was the upper airway problem? Differential. Differential diagnosis for apnea and seizure-like activity in the neonatal period is very broad. Yes, definitely. And the idea is to narrow this differential. It includes infections, meningitis, HIE, sepsis, neurologic pathologies, stroke, bleeding, HIE, which is not in this case at all, mass, genetic abnormalities like inborn errors, yes, electrolytes, yes, upper airway obstruction. You didn't mention that. You didn't mention upper airway obstruction, especially in the setting of syndromes like trisomy. If this baby was trisomy or big with vitamin or Treacher Collins, which is not the case, but it is common in those syndromes. So what was the upper airway obstruction? Diagnosis. The supervising physician notes around pink colored mass along the posterior oropharynx. There was an upper airway mass. They call it epignathes because it's rising from the upper airway, the oropharynx. And pediatric otolaryngology came at the bedside to do laryngoscopy, and he diagnosed a mass posterior to the uvula obstructing the quena, exactly as if it is quenal atresia. The same mechanism of our upper airway obstruction. So don't forget quenal atresia, don't forget upper airway obstruction around the larynx, the uvula, the oropharynx, okay? And then they did a CT that confirmed the mass 1.1 times 2 times 3.5 centimeter. And it was, I believe it was a teratoma, or I don't know what was the pathology. They call it epignathes. Any tumor arising in this area, they call it epignathes. And we did also MRI, and the mass was removed by ENT, and there will be dramatic improvement. The mass pathology, mixture of mature fatty tissue, salivary glands, squamous epithelium, keratin pearls, a focus of dental papillae with enamel epithelium and ameloblast. This is mature teratoma. Mature teratoma. This is the diagnosis pathologically. And they removed the mass. And the baby did very well. Yes, this is the mass. And you see it was obstructing the upper airways. But they saved the life of this baby. And we'll talk about teratoma, how it can present with this, if it's upper airway, dysphagia, rhinorrhea, nasal blockage, respiratory obstruction, cyanosis, apnea, okay? It's known as otopharyngeal teratoma. And they will talk about the details. I will send all this to you. And treatment, of course, removal. And the patient, of course, did very well, extubated, went home. Okay? Lessons. Neonatal epignathes is a true congenital teratoma and may present with prenatal polyhydramnios, as we had in this baby, obstructive apnea, as we had in this baby. Consider obstructive pathologies in the differential diagnosis for apnea, even in non-symptomatic infants. Any newborn baby with apnea, you have to consider obstructive pathologies in your differential. This is the homegoing lesson. Prioritize airway stabilization in the neonate. Of course, the ABCD, airway is number one. And if intubation is difficult, you have other options, including the laryngeal mask, call for a more experienced person, call for an ENT, do laryngoscopic intubation. You still have many options. But if you are on your own, just keep bagging and masking, or if you have laryngeal mask, you can have it. Okay? Know the various causes of stridor in the newborn. This baby did not present with stridor. Know the clinical manifestations and approaches to therapy of neck mass in the newborn. This is the second neck mass we present, but this is inside. We discussed previously an outside neck mass before. Now we are almost 1 hour and 40 minutes. Questions, comments related to this case? Okay. دكتورة مروة, are you with us?
أيوة يا دكتور مع حضرتك.
ازاي حضرتك؟ We will, inshallah, we will continue our sessions on August the 23rd.
تمام.
Saturday, August the 23rd. And inshallah, I'm going to talk about fluid and electrolyte disorders and management in the newborn infant, which was supposed to be given today, but unfortunately we couldn't. We had to reschedule. So I'm going to present it, inshallah, on August, Saturday, 23rd. And I'll advise you and everyone that you know to attend this lecture. It's extremely important because for any pediatrician, for any neonatologist, how to deal with the fluids and how to deal with the electrolytes in the term and preterm baby, in the normal conditions and in the pathological conditions, what type of fluids you are giving, why, based on what are the requirements, and why the requirements change in the newborn infant compared to adults, and why day 1 is different from day 2, from different day 3, why a 40-weeker is different from a 25-weeker. This is extremely important.
دكتور إيهاب، معلش في سؤال في الكيس الأخيرة. معلش دكتور إيهاب.
نعم.
في سؤال متكرر في الكيس الأخيرة. What is the cause of convulsion in this case?
Apnea, hypoxia. The cause of convulsions in this case is hypoxia. When the baby is apneic, the baby does not breathe and starts to desaturate. This baby had desaturation with apneas. And with desaturation, the oxygen supply to the brain is diminished. And that's why the baby starts to seize. Okay? Okay. Any other questions? Okay. What about abnormal? Because this baby had seizures. Because of apnea, there was hypoxia, and hypoxia caused seizure. This baby seized. But the primary cause of all this circle of pathology was the upper airway obstruction because of a mass, which was teratoma. Teratoma caused an upper airway obstruction, was obstructing the both quenas. The nose was as if there is quenal atresia, and caused difficulty with intubation, and caused an upper airway obstruction will cause. It's like a vicious circle. It will stimulate the baby to stop breathing. And the baby will go into hypoxia. And hypoxia will cause more apnea. And with apnea, hypoxia, the baby will start to seize. That's why this condition was confusing, but you should be very cautious. You should have a wide differential diagnosis, especially in a term baby with apnea who has respiratory distress and seizures, secondary to the apnea and hypoxia. You have to think of upper airway obstruction, including choanal atresia. Okay, this is the ongoing lesson from this case. Okay, questions. خلاص, inshallah, we will meet on the 23rd. Thank you very much for every and each one of you. Assalamu alaikum.
وعليكم السلام.
شكرا.
شكرا
وعليكم
جزيلا.
السلام. شكرا لحضرتك.
شكرا جزيلا دكتور مروه.